Great. Thanks and welcome back from lunch. It's too hot out there. You'll get a sunburn, so it's better staying here. That's my 2 cents. You should go back out there at like 3 o'clock when everything's all done here. But anyway, I want to introduce our next guest speaker, Dr. Shaffrey. Probably doesn't need much of an introduction, but just in way of background, he went to college at the Citadel. He played varsity basketball. Played against Michael Jordan, actually, in college, and was crushed by Michael, of course. He graduated magna cum laude from the Citadel with a biology degree, went to UVA medical school, and then he did a internship at the Naval Hospital, residency with Dr. Jane at UVA, and then also a dual residency in orthopedics at UVA, so he's both ortho and neuro board certified, and a spine fellowship at UVA. He spent a good number of years in initially Detroit, then Seattle, then Virginia, now at Duke. I've met his wonderful family. This is a picture from a long time ago. His kids have gotten much bigger now, and every single one of them is taller than me. Chris has done a lot of leadership roles in spine. He's been the spine section president. He's been a AANS president. He's been an ABNS director and head of the board, SRS president, now the CSRS presidential line. I don't think anybody's done all of these things in between ortho and neuro. So a wonderful colleague and mentor, and honored to have him come talk to us here at the Hawaii meeting. And on behalf of Lionel and Lee Tan, welcome, Chris.
Thank you. So basically, I'm really honored to be here, and I've got so many friends over the years from UCSF, and it's such a fabulous place. It's fabulous in orthopedics, it's fabulous in neurosurgery, and it's fabulous in spine. So one of the things with my background is people ask me what's your spine practice like. And I say, I just do what nobody else wants to do. So if there's ever something just truly, absolutely god-awful and miserable, it usually ends up somehow or other me touching them. It was funny, I was really fascinated by that wonderful neurofibromatosis case. And I said, geez, thank God there's other people out there doing it. I thought those things only got drifted in my direction. So I do some pediatrics, and I really, mostly do a lot of co-surgeries where there's something where there's some kind of, VCR needed in a horrible, somebody with a horrible deformity, or there's some kids with some unusual syndromic things which somehow or other seem to drift into my existence. So when I was asked to give this talk about, what's your approach to complex pediatric deformities, I mean, I think that, the stuff that you're seeing here about exactly, what's the best treatment of early onset scoliosis, is it a magnetically controlled rod, or is it Vector, or is it, some kind of, other type of growth device? And so what I figured I would do is I just give a little overview of sort of the recognition and understanding of some of these complex conditions and what the thought process is as far as making a decision whether you take these different things towards surgery. And then I've got another talk, which I'm going to I talked to Praveen about whether I should do something for VCRs for very high grade deformities, and Praveen thought that a thing about treatment of and management of high grade spondylolisthesis. So I'll do that for my next talk. These are my different disclosures that I have. I don't think any of them are going to impact this talk. So basically, I want to discuss identifying the broad categories of pediatric spinal deformities. I want to highlight the importance of determining, if you can, the etiology of the spinal deformity, because different etiologies have different impact on growth rates and risk of neurological problems and risks of having other bodily manifestations of certain different syndromes. We want to discuss some principles of management, and then touch upon some some strategies to deal with these. So what's happening is that pediatric deformities can come in many different, shapes, sizes, and presentations. And, even though that when you have someone that has a significant deformity, they may, from an external perspective, some of these things may look similar, but the actual cause of the deformity can be substantially different. And so, here are, different people who have, scoliosis or kyphoscoliosis, and, one of them is, kind of a relatively new onset scoliosis in a 13-year-old girl who it turns out ends up having idiopathic scoliosis. We have a bit older kid with cerebral palsy who had, through the years, had kind of brace treatment and then suddenly was having significant difficulties with sitting in the wheelchair, and in fact was developing some skin breakdown related to his poor fitting and due to his spasticity. And again, once the person had a bit of an ischial and sacral osteomyelitis, then it became suddenly send it to Chris to take care of. Here's an infant who's not passed any stool, who's got another syndromic case, and then finally yet another case with significant shortness of breath and again pain with sitting. And so what's happening is these complex pediatric deformities can really be developed, can be categorized into sort of 5 broad categories. The first one is idiopathic, and that can be either early onset or idiopathic adolescent scoliosis. But you can go with early onset scoliosis, develop really, horrific deformities. And some of the stuff that was, some of the literature and some of the early treatments that were done were because if you had early onset scoliosis 100 years ago, it was basically kind of a death sentence for you in some cases. The second category is congenital, and there's a big spectrum of those. And that's, it's usually a failure of formation or a failure of segmentation or a combination of them, and understanding how many areas are malformed, whether it's incarcerated or whether there's growth potential related to, particularly for hemivertebrae, and then bars, have a really a growth arresting component, depending on where they're located and how they're combined together, can again have a big impact on the risk of progression. There's neuromuscular scoliosis, things like cerebral palsy or Duchenne's. There's mesenchymal problems, including osteogenesis imperfecta or Marfan's. Then finally, some syndromic conditions, Down syndrome, Prader-Willi, and other different conditions. And so understanding what things are going on become very, very important. So what's happening is that identifying the root cause is really crucial. And I think this is a kind of a classic example for this young lady here, where she's got this scoliosis. Scoliosis doesn't appear to be particularly bad, but the reality of it is seeing that tuft of hair really makes you think that there may be something underlying. And it turned out this young lady had diastemotomyelia, which would really impact your ability to treat it. And we could have a debate, Barron or whoever could have a debate, hey, do we do this? Do we take out the diastem at one time and do a correction, or do we do this in separate settings? Or, in fact, if you actually operated early enough, perhaps with this kid, by taking care of the diastem, you may not even have to do a fusion necessarily in this child. And these are all things where, unfortunately, the numbers are low enough that it's hard to come up with really firm information as far as that's concerned. I think a detailed physical examination becomes really important. You can see for this case the difference in the lower extremity bulk and appearance of the muscle, the cavus foot, the calf atrophy, and this turned out to be Charcot-Marie tooth disease. And why this is important, not only for understanding the natural history and the progression, is that there's a much higher associated risk of cardiac arrhythmias. So your anesthesia team really needs to know what exactly you're dealing with when you're doing some of these different cases. With congenital scoliosis, there are a variety of different associated congenital malformations because the same event that likely led to the congenital thing occurs during the same time of embryogenesis, where there's formation of the urological system, cardiac things. So it's very common to have urological abnormalities, and that's why, as I'm going to show you in a subsequent slide, getting an ultrasound of the kidneys is important. Cardiac abnormalities are common. Having some type of intraspinal neurology is very common. Somewhere between 25% or a third of people will have some type of interspinal abnormality. And then there's other different things like Vater syndrome, where you have associated factors such as cleft palate or esophageal atresia, other things going on with that. So it's important to get a thorough evaluation, and usually working together with the child's pediatrician is really important. So what's happening is that for all kids, there's a relationship between curve progression and spinal and overall growth. And one of the things why kids with very young onset deformity are really at risk is because you can see how rapid the growth rate is, from birth up until about 3 years of age. Then there's a second peak with adolescence, where again you can have a real rapid progression of any existing scoliosis. And so the growth potential predicts the risk of curve progression. And one of the ways to go and assess that, there's a variety of different things, including radiographic measurements, the wrist, and other places to go look. And there's a relationship between peak growth and these radiographic parameters. And these, again, guide some of the treatments, such as bracing or the need for surgery, or other factors that go on. Now, one of the things which is really important is you're always balancing how bad the curvature is going to be and what the impact is on spinal length. And so one of the goals is to try to maintain spinal length as much as possible, so there's not an exceptionally shortened trunk. As you can see, these different growth of spinal length in centimeters between the different areas of the spine. And so one of the decision-making factors is, are you going to go and actually improve things enough and to make up for the potential shortening? And that's why you're seeing such an enthusiasm for certain growth maintaining treatments. And one of the things with that, which I'm sure that Baron and others are going to get into, is the sort of the psychological trauma and the surgical trauma of certain systems which require repetitive lengthenings, and things like magnetically controlled growth rods and other treatments are trying to get away from kind of the trauma to allow growth to occur. So this is, again, this is a thing that's commonly used for idiopathic scoliosis, is the retrograde and the association between growth and the different retrogrades with the apophysis of the ilium. And this gets back to sort of recommendations, for example, with idiopathic scoliosis, whether something can be just observed, whether it can be braced, or whether surgery is indicated in broad strokes of things. So with congenital scoliosis, again, as we talked about, there's a risk when something has just a fully segmented hemivertebrae. The growth potential per year is between 6 and 9 degrees. For an unsegmented bar, it arrests that side and can result in deformity between 4 and 5 degrees. And so if you have a semi-segmented, it's less, If you have basically an incarcerated vertebrae, it's less still. And so knowing these different things and being able to count and see whether they balance or unbalance the spine are factors that are taken as far as the decision making to proceed with some type of surgical intervention. Certain conditions such as Duchenne's muscular dystrophy and cerebral palsy also have risks. And again, these are a little bit harder to determine, but basically with Duchenne's, is the risk of progression is somewhere around 7 degrees a year. And for cerebral palsy, again, depending upon the severity of the cerebral palsy and whatnot, can be up as high as far as 20 degrees. And one of the problems with these are very unresponsive to bracing, and again, can result in very significant magnitudes of curvature. And that's why the need for treatment. As a general rule, idiopathic scoliosis is kind of a lordosing condition, whereas these neuromuscular scoliosis are generally associated with a progressive kyphosis in addition to the scoliosis. And so it's important to take these different factors into consideration if you are doing a treatment for them. So basically, one of the things we're always concerned about, as I said, there's, everybody tries the best they can to avoid surgery. And there's a variety of different factors, and probably a full, different, morning or afternoon talking about the different things with bracing and treatments for early onset scoliosis. But you can see here this one kid, and again, some of it is the rib, vertebral angle differences and other different factors that can help you predict when bracing may work. But with people who would develop a significant curve, you can see this is why it can potentially become a life-threatening situation. And so what's happening is, serial casting is something that is often tried to go and to prevent the need for surgery at a very young age. So again, this is showing, with observation and bracing, you can get these horrific curves, and it likely would have been that a surgery, even though it does limit the truncal growth, would have been better in this young person than continued observation. And so one of the problems is that as the curve becomes worse and worse, the size, magnitude, and risk of the surgery becomes higher as well. So there are a number of different factors in AIS. One of the most common reasons why surgery is done is for aesthetics, but there are cases that significant magnitude of curve can result, and again, most people feel that somewhere in that 45 to 50 degree range with growth remaining is when most people would consider doing surgery. I think there's a lecture that either was done today or just tomorrow on vertebral body tethering. I think that may be something in the future that may be an alternative for some of these kids versus a traditional spinal fusion. So basically, the surgical plan, as I said, I usually do the stuff that nobody else wants to do. So this is a kid with a severe kyphosis related to myelodysplasia. Fortunately with that, most of the people that have this don't have very good leg function, so it makes it a little bit safer an operation. This was an operation that was done years ago, actually done during my fellowship, where a kyphectomy was done, and you can see the overall improvement in positioning and alignment. This is another early onset case treated years ago with a Vector to try to go and correct it, and then finally a neuromuscular case with severe pelvic obliquity with treatment for that. So basically, again, this is sort of a whirlwind of just an overview, for the general spine practitioner. But really, you want to define the deformity. We sort of went over what the natural history of the different deformities were. You want to determine whether it's scoliosis, kyphosis, the degree of sagittal and coronal imbalance, and sort of how the sitting posture goes. You want to exclude any underlying abnormalities by physical examination and other imaging testing. You need to know what other comorbid pathologies may be existing with the conditions. You need to know what the natural history is and assess the risk of progression. And if you, at that point, intervene if you can positively alter the natural history of the condition. So basically, that's kind of a whirlwind overview of complex pediatric deformity. And as I said, I think any one of the subgroups of that is something that we probably could spend a series of lectures on. But I'm happy to answer any questions. Questions or anybody, or everybody's stunned and sated from lunch today? The nice lunch we had outside.
Maybe I'll start off with with these complex cases. Certainly, neuromonitoring and managing motor loss is a real possibility and important consideration. Do you have any pearls for what to do when you don't have great motors, and how you can still perform those cases safely when there's not good baseline monitoring?
Well, I think that there's certainly risk, and one of the differences is if you have somebody that's sort of cognitively intact that can go and respond to doing serial wake-up tests and whatnot. So in general, let's just say somebody has a congenital kyphosis or kyphoscoliosis who's myelopathic. And an example would have been that great case that you guys showed earlier. That's a case that if I did not get good signals, I would have prepared the family and the anesthesiologist to do a series of wake-up tests. So what I would have done is I would have gone and likely kept the patient, to try to get a baseline when they're supine, and then keep them sort of light on propofol or whatnot and position them. Because a lot of times, at least for me, I'll get a signal loss with positioning, particularly with a kyphosis. So what we'll do is we'll make sure that they can wiggle their toes after positioning, and then they do it deeper. Then after each major step in the operation, I'll go and do a wake-up test. So Rob Lark, one of the ped guys at Duke, really good guy, he and I did a big, horrible congenital scoliosis. And we basically, woke the kid up after positioning. We put all of our screws in, and he was not moving his legs. And so we actually took him off. We went and I wanted a high quality CT scan. We did a intraoperative 3D spin, but I wanted to see. And basically, when we put him back supine with the screws in, by the time he's done a CT scan, he's wiggling his legs again. So this thing can be very difficult as you do each of these different steps. Now, for older kids and adults, the one thing that I've done, and this is off-label, is I've been putting the kids on 10 days of Riluzole before I've been doing the cases. Then I continue them on it for 10 days afterwards. And it may be just I'm treating myself, but knock on wood, despite having some really horrific deformities, I've not had anybody with a permanent deficit since I've started doing that. So for me, if you have signals to follow, that's best. If you don't have signals, or very unreliable signals, a wake-up test. And those ones who are cognitively impaired or whatnot, some of that's a discussion preoperatively with the parents, and that, if the child understands it, I'd say, hey, this is a very, very risky case. So the things that really scare me, the ones that are really the worst, I think, are bad congenital kyphosis cases. I think they are the highest risk of having a postoperative neurological deficit.
Chris, really nice, thorough overview. You know, I remember, I think it was Keith Bridwell, I believe it was at an SRS meeting 20 years ago or so, maybe longer. He said, it's time that we bring neurosurgeons into the mix. And Keith, really, that was a push for him. So how do you see neurosurgeons and orthopedic surgeons working together, cross-fertilizing, and the continuum of life from peds to adult, and how do you see the future play out with our specialties?
Well, you know, I think that one thing that is different, and the reason why I did 2 residencies was that when I was in training, and this is, you know, in the 1980s, in orthopedics, you just didn't see stuff, and it was thought to be that you were a real, a hero if you would take down the PLL to do an anterior cervical discectomy, let alone doing a vertebral column resection procedure. So what's happening is I think everybody brings different things to bear. The one thing that I would say for most everybody is if you're doing a really big case, okay, that's going to take you multiple hours to do it, to have an experienced partner in there helping you do that case is something that is an advantage. And there are certain things like, for example, the neurofibromatosis case. You have some cases with dural ectasia, and suddenly you have nothing. You open it up, and there's like nerve roots and a puddle of CSF that's there. And kind of knowing, at least for me, I've seen enough CSF during my career that I don't completely freak out about it. What I'll do is I'll essentially reestablish a dural tube by using a dural substitute. And usually, if you're doing a VCR or a PSO and you're closing it all down, you don't seem to get the same thing. So what's happening is I think collaborating with different things is helpful. And you don't want to do it at the world's worst absolute moment to collaborate. The one case a year that's the total disaster. So I think interacting. And what happens is that for a lot of years, I would go for a week and go visit somebody, whether it was Jurgen Harms or whether it was Zilke or whoever, particularly earlier in my career. And you'd always come back with some things that you learn. And I'll tell you, if you go and if I'm sure that if I scrubbed in with Sig or, Lee or any of the people that are here, I would learn something about doing it. So I do think that, some of the stuff, your comfort level about, where to tie off a nerve root, you want to make sure you do it proximal to the dorsal root ganglion. You don't want to cut through the dorsal root ganglion. There's different things that you can learn from your colleagues. And, and I learned stuff, every one of these meetings, I'll come away with some new, really neat trick. And one of the things which I think is so great about these meetings is, I'll sit there and I'll have a cocktail with Sig, and he'll be telling me about some case he did, and I'll say, "Wow, that was a really, really very good idea on what you did it." So I think the more that we collaborate with each other, we're all basically on the same team. It's just like saying, okay, if you're the center and somebody else is the wide receiver, that doesn't mean that you guys are at odds. You may approach doing something a little bit differently, but working together, I think, is really important. And and I just think it's a good thing to do and establish that relationship.
Thank you for the great talk, Dr. Shaffrey.
Good.
I just had a quick question.
Sure.
Going back to the neuromonitoring. For sometimes we do like patients with cerebral palsy with that are very fully involved, not any meaningful function, but as standard of care, we still use neuromonitoring. Do you think there's any role in just kind of skipping that and not doing neuromonitoring And because, I mean, kind of why are we doing it? So I sometimes ask myself that question, but we just do it because we do it for everyone. What are your thoughts on that?
Yeah, I'm going to tell you. So I think where you see this, or I see it, and I don't know if you guys have the same problem at your all's institutions, our neuromonitoring team and our anesthesia team, if anybody's had any history of seizure disorder, they do not want to do motor evoked potentials, okay? So some of the stuff I've tried to get away with that is kind of do D-wave monitoring, some other things like that to try to get around that. But I really don't, I would say probably 6 or 8 or 10 years ago was at my peak where I was sort of paranoid about monitoring. And I monitored it and I said, well, let's just go ahead. But what I found was a lot of these people, adults and kids, where you have some real compromise, you're suddenly, when you lose the signals, then you're totally, then it goes into the whole kind of medical legal thing of, gee, should I have acted on this? Should I have stopped? Should I have done all that? And I think it's a real gray area. What do you guys think? I mean, I'd like to hear, because this is sort of a panel discussion thing as much as for me. So I do less monitoring than I used to, okay? Because I do find that in a lot of these cases, it's somewhat unreliable. Sig, what do you do in these cases?
I think it has a lot to do also with the resources. So at UCSF, we've got a 7 full-time neural monitoring faculty, and it's pretty difficult, or it's pretty accessible. And I think the accessibility of this is maybe part of my decision making. And quite honestly, I probably overuse neural monitoring. So I had a debate with Ed Benzel at Cleveland Clinic, who says there's no role for neural monitoring in a cervical myelopathy, right? So I monitor all my laminoplasties, all my cervical lamina fusions, certainly monitor all my deformity. Now, I'll also admit that I actually have neural monitoring for my disc herniations. If a patient's got a neurologic deficit, I like to monitor a disc herniation with a neurologic deficit. I actually measure the nerve root and give them information on, hey, what's the status of the nerve root? So I might overutilize it, but we've had so many examples, and I know Praveen's here and others that I've worked with in line. We do a lot of co-surgeries, and we've had so many examples of motors dropping out on a cervical lamina fusion case, on a congenital scoliosis case, et cetera, where their nerve monitoring saves, where, hey, we see a change, and then we'll do something. Typically what we'll do is we'll actually shorten the spine further and increase pressure. Being's written a whole protocol on the steps. So in my hands, I virtually never do a deformity case without nerve monitoring. Maybe somebody else wants to take an alternative position.
Well, and I'm going to say when I trained and my fellowship was pediatric and adult, things like things that neuromuscular scoliosis cases we never, we put multiple sublaminar unit rods, multiple level corrections, and we never ever monitored those. Okay. And I always say, in my mind, is there something that I can distinctly reverse a step and make a save, okay? And if I don't think I can do that, I'm becoming less and less convinced that it's worth the time, effort, and hassle. I was going to ask Baron, your neuromuscular cases, do you monitor them?
We try, Chris. We try. Don't always have a reliable baseline, but I think most of the time we're able to get something, and we use it.
I agree. I monitor neuromusculars. I'd say easily 25% of the time there's not reliable enough data to monitor. But I do think that even with tetraplegic involved kid, they can have changes in sphincter function and other things from stretching the cord that we may not appreciate while they're in the house, in-house for 6 or 7 days, but their parents who, are kind of taking care of them will appreciate.
That's a great point. Well, good. Well, thank you, everybody. And I really do appreciate the opportunity to be here.